Hi, it's my pleasure to talk about antibodies in hematologic malignancies. So as I am a lymphoma doctor, I'm really going to be focusing on how we use antibodies in lymphoma, and I'll be talking about monoclonal antibodies or naked antibodies, as well as modified antibodies, including antibody drug conjugates, CAR-modified T cells, and bispecific antibodies. So in lymphoma, we really take advantage of the fact that we can modify monoclonal antibodies to have various different functions in various different diseases. So starting off with the main antibody, which contains a variable region and the constant region, modification of various parts of this could allow us to enhance its activity in various different ways. So the most common monoclonal antibody that we use in lymphoma is an IgG1 monoclonal antibody. And this type of antibody has the ability to induce antibody-dependent cytotoxicity. And through modifying parts of the constant region of the antibody, either the carbohydrate or actually the constant region sequencing, we can enhance antibody-dependent cytotoxicity, and that's done through glycal modification of the carbohydrate moiety or through altering the amino acid sequencing of the constant region. And there are various monoclonal antibodies that take advantage of this mechanism. We also sometimes use monoclonal antibodies that are IgG4, and the advantage of these is that they are not capable of antibody-dependent cytotoxicity and instead work by just binding their target, so they don't kill their cell, they kill the cell that they bind to, and this is helpful in blocking signaling or blocking targets. Antibodies can also be linked to either radiotherapy as well as drugs, and I'll be talking about specifically antibody-dependent antibody drug conjugates in specific. And then the variable portion of antibodies have been used to develop these chimeric antigen receptor modified T cells, which I'll talk briefly about, are now FDA approved in lymphoma. And then finally, antibodies have been used to develop bispecific antibodies, which are now appearing to be very active in lymphoma and are likely to be FDA approved soon. So beginning with the monoclonal antibodies, as I mentioned, we often are using the IgG1 type monoclonal antibodies, and these are function by inducing antibody-dependent cytotoxicity or complement-mediated cytotoxicity. We also sometimes use IgG4 type antibodies, which can work by just blocking their receptor or blocking their ligand. So as an example of some of the main antibodies or monoclonal antibodies that we use in lymphoma, and this is not an exhaustive list, but these are some of the most common ones that we use. We have rituximab, which targets CD20, which is almost universally expressed on B-cell lymphomas, as well as normal B cells. This is an IgG1 type monoclonal antibody and works by complement-dependent cytotoxicity as well as antibody-dependent cytotoxicity. Obinutuzumab represents a modification of rituximab or potentially an improvement upon rituximab, as it has a modification in that carbohydrate group, and as a result can induce and can better enhance antibody-dependent cytotoxicity. And it has been found to be more effective in indolent B-cell lymphoma, particularly follicular lymphoma, as compared to rituximab. Although in the aggressive B-cell lymphoma, such as diffuse large B-cell lymphoma, it was not found to be any better than rituximab, but it is approved for the B-cell lymphomas and commonly used as well. I'm going to show you a little bit about mogamulizumab, which targets CCR4 and we use in various T-cell lymphomas. Alemtuzumab is a monoclonal antibody that also targets T cells. It targets specifically CD52, which is expressed widespread in on T cells. And then finally, two monoclonal antibodies that are IgG4, so they really are function as blocking monoclonal antibodies, are pembrolizumab and nivolumab, which work by enhancing anti-tumor immune responses. And these are drugs that we use very commonly in Hodgkin lymphoma, and I'll show you a little bit about that. So rituximab is one of the oldest antibodies that we use in lymphoma, and I just wanted to start by showing this classic study in which rituximab was combined with CHOP and compared to CHOP alone in diffuse large B-cell lymphoma. And this led to changing the standard of care for B-cell lymphomas. And as a result, rituximab is incorporated into many of the treatments that we use for B-cell lymphoma. As I mentioned, mogamulizumab is an interesting monoclonal antibody. This is one that wouldn't be, is not as commonly known since it targets diseases that are not as common. And this targets a marker called CCR4. CCR4 is expressed on certain specific types of T-cell lymphoma, and in particular, it's expressed on cutaneous T-cell lymphoma, such as mycosis fungoides or Sézary syndrome. It's also expressed on the cells that develop into HTLV1-associated lymphoma. So this monoclonal antibody targets these tumor cells and induces antibody-dependent cytotoxicity. But interestingly, the CCR4 is also expressed on T regulatory cells, so on normal T regulatory cells. So this monoclonal antibody also leads to elimination of T regulatory cells. And so as a result, this monoclonal antibody really has a dual function in that it can attack the tumor cells, but also induce an anti-tumor immune response by reducing circulating T regulatory cells. So this is a drug that's FDA approved for cutaneous T-cell lymphoma, and that was based upon this phase 3 randomized study in which mogamulizumab was compared to what was considered to be a standard of care in T-cell lymphoma, which is vorinostat. And this was specifically for patients with cutaneous T-cell lymphoma who had received one prior systemic therapy. And what was found was that the mogamulizumab was much more effective in treating cutaneous T-cell lymphoma compared to the standard treatment, whereas the overall response rate was 28% compared to 5%. And interestingly, this drug was particularly useful in reducing the amount of disease in the blood for patients who had circulating disease, where 68% of the patients had reduction in the burden of disease in their blood. And so this is a drug that I tend to use fairly commonly in patients who have Sézary syndrome, which is characterized by a cutaneous T-cell lymphoma with circulating disease in the blood. So I've already alluded to the PD-1 blocking agents, nivolumab and pembrolizumab. And as I mentioned, these are drugs that we use very commonly in Hodgkin lymphoma. And Hodgkin lymphoma turned out to be a good candidate for evaluating PD-1 blockade, and that's based upon the fact that the ligand for PD-1, which is PD-L1, is almost universally expressed on the tumor cells for Hodgkin lymphoma, which are the Reed-Sternberg cells. And it's expressed due to amplification of the 9p24 chromosome, which contains the genes for PD-L1 and JAK2, which then further enhances expression of PD-L1, or through EBV, which is associated with about 40% of cases of Hodgkin lymphoma. So there's universal expression of PD-L1, and it's felt that this is related to the immune evasion that we typically see with Hodgkin lymphoma. So both pembrolizumab and nivolumab were evaluated in relapsed refractory Hodgkin lymphoma. And as you can see from these waterfall plots, nearly every patient who received these drugs had some kind of clinical benefit, and the overall response rates were quite high, ranging from 65 to 70%. And it turns out these drugs are really more active in Hodgkin lymphoma than really any other disease, although these drugs are used in other malignancies as well. And based upon this very impressive activity, these drugs have now been incorporated or are being evaluated in clinical trials, both in the frontline and second line setting for Hodgkin lymphoma. So moving on to antibody drug conjugates. So an antibody drug conjugate has three important features. The first feature is the antibody, which is designed to target a specific antigen, and the hope is that this antigen is on your target, is frequently on your target, but also is not on many normal cells as well. And the antibody is linked to a cytotoxic agent, which is shown here, which is some kind of a drug that is highly potent in small quantities, but is not toxic when it's actually attached to the antibody. And then this antibody is attached, the toxin is attached to the antibody through this linker, and this linker is supposed to be stable in the blood, but can be broken once this entire complex is brought into a cell. So it turns out that Hodgkin lymphoma was another disease, is the disease where this class of drugs has also been developed. And Hodgkin, I'm showing you a cartoon of a Hodgkin lymphoma pathology, but basically it's characterized by Reed-Sternberg cells, which are defined by expression of CD30, which is the target of an antibody drug conjugate. So Reed-Sternberg cells universally express CD30, and then they happen to also be surrounded by this vast inflammatory network of cells. Another disease that's defined by expression of CD30 is a type of T-cell lymphoma called anaplastic large cell lymphoma. And showing you here the immunohistochemical staining showing that this disease is really defined by sheets of CD30 positive cells, so not just rare CD30 positive cells that we see with Hodgkin lymphoma. But based upon the fact that both of these diseases are always express CD30, there was, understandably interest in looking at monoclonal antibodies that target CD30. And there were various different studies evaluating this in both of these diseases. And the response rates were a little disappointing, though, with no more than 27% of patients responding, but really the response rates were quite low. And so this was not felt to be that exciting. And then what really changed the field was the development of an anti-CD30 antibody drug conjugate. And so this is rituximab, which targets CD30 and is linked to a toxin called MMAE, which is an antitubulin agent. And it's linked through this linker, which is a protease cleavable linker. And the way this works is that this entire complex binds to a cell that expresses CD30. It's brought into the cell through a lysosome, and then within the lysosome, the enzymes there can cleave off the drug, and which can then act as an antitubulin agent and result in apoptosis of the target cell. Now, importantly, and probably more importantly for Hodgkin lymphoma, once the cell dies, those chemotherapy molecules or chemotherapy drug toxin is then free and can be released into the microenvironment and kill some of the surrounding cells as well, which is helpful in a disease where the target is actually not that frequently expressed as we see in Hodgkin lymphoma. So similar as we saw in those in the drugs that target PD-1, Brentuximab is highly active in Hodgkin lymphoma. This is the results from one of the original phase 2 studies looking in relapse and refractory disease, where 76% of the patients had responses. And likewise, Brentuximab is highly active in relapse refractory anaplastic large cell lymphoma, with even more patients having responses in this disease. And in both of these diseases, Brentuximab is now FDA approved to be incorporated into the frontline treatment and in combination with chemotherapy. So in addition to Brentuximab vedotin, there are two other antibody drug conjugates that are approved in lymphoma. One of them is Polytuszumabidoten, which targets CD79B, which is used in B-cell lymphoma, and then Lonca, which targets CD19 and has a different toxin associated with it, which leads to breakage of DNA. And so both of these have activity in diffuse large B-cell lymphoma. And in fact, Polytuszumabidoten it appears to be, has been evaluated in the frontline setting for diffuse large B-cell lymphoma incorporation with rituximab plus CHOP, and at least the initial results from the study indicate that it is improving outcomes for patients, and this may result in becoming a standard of care in the frontline setting for diffuse large B-cell lymphoma, but we're still awaiting more formal results from the study. So shifting gears to another way that antibodies are modified, and this is just absolutely fascinating that this field is absolutely fascinating in that this is an example of how a part of the antibody is used to design chimeric antibody, design T cells that can attack target cells. So shown here is a normal T cell that contains the T cell receptor. And here's a target cell that is presenting a tumor antigen. And you can see that the T cell receptor binds to the tumor antigen and contains the CD3 signaling structures that lead to activation of the T cell. And the chimeric antigen receptor has been designed to have some of the important features of the T cell receptor. It has the region that will recognize the tumor antigen, but this region is developed from the variable region of an antibody. And then that is bound to a transmembrane domain. It contains the CD3 signaling domain, but it also contains this co-stimulatory domain, which is either derived from CD28 or 41BB, which is important to ensure that this T cell is active and can act on this target cell. So these CAR-modified T cells are autologous cells, so they're T cells that are collected from patients, and then they're modified to express this chimeric antigen receptor and then infused back into patients so that they are designed to then target the tumor cells. There are three CAR T cells therapies that are approved in diffuse large B-cell lymphoma. I'm showing you the abbreviations for them, or the short names for them. They include Axi-cel, Tiza-cel, and Lysa-cel. There are some mild modifications in the design of these. So for example, all three of these target CD19, so they target, which is a marker on B-cell lymphomas, so they target B-cell lymphomas. The Axi-cel has CD28 as its co-stimulatory domain, whereas the other two have 41BB, and then all three, of course, have the CD3 T cell activation domain. There are some differences in how the clinical trials for each one of these agents was designed, including eligibility and manufacturing of the CAR T cells. And so it's very difficult to compare these agents, but basically all of them show significant activity in diffuse large B-cell lymphoma, including complete responses. And given that this is a patient population that were treated on these studies that were heavily pretreated with limited treatment options, this was very exciting and led to, and all three of these agents are approved, and many of these patients actually have quite durable responses to these treatments. The last thing I'm going to touch upon are the bispecific antibodies, which are antibodies that have two different targets. And I'm showing you here ones that target CD20 and CD3. And basically the way these work are by directing CD3 cells, positive cells, so activated T cells or immune cells, in close proximity to the target tumor cells, so that an anti-tumor immune response can be achieved. And so there's various different bispecific antibodies that have been developed, and a summary of them are shown here. And they differ a little bit about whether or not they have a constant region, or and how the constant region is developed, and whether or not they have two targets for the CD20, the ratio between variable regions for CD20 versus CD3. So there's some differences. But as far as the activity of these agents, I'm showing you the four that are furthest along in B-cell lymphomas. They're being evaluated in both aggressive B-cell lymphomas as well as indolent B-cell lymphomas, and there's activity across all four, and likely that we're going to see a FDA approval of these agents, and they're already being evaluated in clinical trials in earlier on in both the frontline and second line setting for these diseases. So with that, I'd like to thank you for your attention. As you can see, there's really widespread use of antibodies and modification of antibodies in lymphoma. Many of these are already in use and have already impacted our frontline treatment for these diseases. And it's exciting to see that bispecific antibodies are very far along and will be impacting our treatment as well. Thank you so much for your attention.